don't have to ask anymore. So my plan is I'm gonna kind of like how they did during COVID. It's just do a quick, like it won't be long because neuro isn't that long, but just a quick, like, this is what you should focus on in your study. This is what you probably don't need to worry about, that kind of stuff. And I will send that out this week before Saturday. And you don't have to watch it before Saturday, but Saturday I'll be here, I'll be in town. And we will do a Kahoot for your practice or for your test on Tuesday. And then we'll just have to talk about, because next Tuesday, you guys won't be learning any more new material. So I don't think, like, I think that the next time we meet should probably be the Saturday, like, it wouldn't even have to be the Saturday after Thanksgiving, right? I don't know. What are your guys' thoughts on like we'll definitely meet before finals to do like a final exam review. But do you feel like we need to meet next Tuesday? Like, I'm just thinking calendar wise, like you're not going to be learning any new material. I think it's just the test and then you're doing your presentations, right?
I have a question.
Yeah, go ahead.
So for the final, we have like a Kahoot to review.
Yeah, I'll make a Kahoot. And then I did send out, I know that Martin gives a final exam review and Sangil should too. She did for our farm class, so I'm pretty sure she would for you guys as well.
Got it.
She already sent it out?
Yeah,
Yeah.
and Gil did.
Okay. Did Martin send hers out yet or post it?
Yeah, she did.
Okay, so check with like what I sent, because I sent you guys mine, right? My final exam review. No? Okay, I'll send it tonight. I thought I did. But I'll send it and just double check because like Martin, I know changes it every semester. Well, that's what she says. So it might not be like all of the same stuff, but you should have a lot of the same material that you can kind of copy or not copy, but just kind of like use as a resource. And I would just double check like what I put because I'm human and I make mistakes. So it's possible that I wrote the wrong symptom for something. So just like, I think it's a good resource, but don't like just completely depend on it. Just do your own, like use it as a resource. So I'll send that out tonight. So let me pull up my calendar. I mean, we can meet as many times as you guys want. I don't mind. I just don't want to also like, I know you have your ATI exam for psych to study for, so I don't want to take up too much of your time with that either. Let's see.
Lauren, quick question on the psych ATI. Do you feel like the questions were similar to that, like the A and B that you took, or were they a little?
Yeah,
Okay.
so they weren't the same questions, but they were similar. They were not similar to like the tests you've been taking in psych. They're more similar to like ATI. And so I would do those tests a few times until you feel confident, and then I would do ATI dynamic quizzing. Do you guys know what I mean when I say ATI dynamic quizzing? You know what that is? Okay. If you don't, ask a friend who's nodding, like Adam or Joey. So do ATI dynamic quizzing, and on our exam, it was pretty heavy on psych meds, which I was not prepared for. I know it changes every time, but I would just beef up on your psych meds. So let's see. So today is the 14th. So Saturday the 18th, we'll do a Kahoot exam review for your exam on the 21st. And then I think we should probably just skip the 21st, like PAL, unless you guys want to do something, because it's before Thanksgiving and people are traveling and stuff. We can do one on Saturday the 25th if you guys want, like maybe like a practice for your psych ATI. Like I could have some practice questions we can go over if you want. I don't know, like what are you guys, does that sound good? Or do you want to do something different? Armando's saying thumbs up. Okay. So I'm thinking let's skip Tuesday, and I'll send out an email so you guys don't have to remember this. I'm thinking we'll skip Tuesday the 21st, so that way we can just kind of have Thanksgiving off and there's not really any new material to cover. Saturday the 25th, we'll do like a practice ATI. We'll just go over practice questions and discuss them. I think we should skip the 28th because the next day is your psych ATI exam, and I want you guys to just focus on your ATI and your study. And then on the 2nd, we can do a final review for for med-surg. And then on the 5th, that Tuesday evening, we can do a final review for psych, because you'll take psych on the Wednesday, the 6th. Does that sound good to everybody? Any major problems with that? Okay, I'll make a little like calendar and send it out so everybody's on the same page, and then I'll send you guys reminder text. So I just want to see if there's anybody that really wanted to meet the week of Thanksgiving, because I'm in town, but okay. So let me put in the chat, just the sign in. Oopsies. Okay. So we're going to start with endocrine. And I sent out my notes earlier last week, like I think on Saturday or something, I can't remember. Oops, I always hide the wrong thing. Here we go. And I hadn't like gone through my notes yet. So everything that was like written on there was just stuff from when I was in second semester, my own notes. So I did change a few things, and I can resend out my notes with just kind of what I changed, because I did take off some stuff that I was like, you don't need to know this. I went way too deep, and I just added a couple things. So we'll go over that. So this is what Martin had posted on her Canvas, at least for us. And this is just FYI, there was nothing on our test about A&P. And normally on the test, I don't remember there ever being A&P on the test. That's normally the quizzes. So I would not worry about any of this. Same with this. It's just your own. And same with this. I went way too deep into this, so don't worry about any of that. Let's see. Okay, so I would know your test. So for Addison and Cushing's, one of the big tests they're looking at is cortisol. They're looking to see if it's elevated or if it's decreased. So in Addison's, you're going to see decreased cortisol, and in Cushing's, you're going to see elevated. And the way that I remembered that is that Cushing's is like a cushion. And so like they're really cushy and like chunky. And so when you're stressed, you produce cortisol, and like we all know in nursing school, we're so stressed, we produce cortisol. Everybody gains weight in nursing school. Like, I mean, at least I do. I think hopefully we all are. It's not just me, but we get all cushy. And so I just think Cushing syndrome is like cushy or a cushion. And so it's fat producing, which is cortisol, because we produce cortisol when we're stressed, which makes us fat. And then Addison's is just the exact opposite. And so that's how I remember that. You will want to know no food or drink 2 hours prior to test. I don't know. I know that Martin really likes her, like, this is the gold standard test, and like this is like the pre-op what you would do, or pre-procedure. Does San Gil focus on that at all? Like, know that it has to be like no food or drink 2 hours or anything like that?
Like before surgery, or?
Yeah, like I know that Martin like loves these questions. Like
I think it was
before
like
this
6 to 8
test.
hours for us, like before surgery, but that was like on the other one. I'm not so sure.
I think
Okay.
sometimes he does. It depends.
Okay. So I know for Martin, we had a question kind of like this where it was just with the cortisol, it was like first of all, like what would you expect to see for Addison's or Cushing's? And then what would you prepare them for? So no food or drink 2 hours prior. For contrast, you should know by now that we need informed consent. And because we're injecting them with iodine, if they have an allergy to iodine, or shellfish, then we're not going to do that, because shellfish has similar components as iodine. So if they have allergy to either one, we're not doing that. We're not giving contrast. We'll go over this. This is just like all together and my little notes. So we will go over all of this like as we go. I think it's too much information altogether. So I'm just going to skip it right now, but we're going to go over it one by one as we go through. Make sure you know your age-related changes. I think that's more for the quiz. I don't know on your test if you do age-related changes. But just know that remember your pancreas releases insulin. And so if you have a decrease in your pancreas mass, then you have less insulin to be released. And so you're going to have problems with possibly getting diabetes or just high glucose levels. So that's that increased insulin resistance. Okay, so this is just explaining, this is more kind of for your own just so you understand, so the pituitary gland in your brain releases ACTH, and that acts on the glands, on the adrenal glands, which sit on top of the kidneys, and then they release cortisol. So this is like part of the whole, like one hormone tells another hormone to get released. And then the cortisol goes into the bloodstream and affects all of these things. And so with Addison's and Cushing's, what's happening is it's affecting the pituitary gland one way or the other, or it's affecting the release of ACTH. And so it's affecting this whole pathway. So if this isn't getting released, then the adrenal glands can't release cortisol. And so you have no cortisol in the blood, and that affects all these. Or if too much of this is getting released, or you have too much cortisol getting released, then you have all cortisol. And again, it affects all of these systems. So even though it's just one little hormone, it affects like systemically our entire body. The only reason they do a CT scan is just to rule out a tumor. So there's lots of cancers that can cause similar, like if you have a tumor on top of your adrenal glands, then that's going to cause like similar signs and symptoms. But then they're going to treat it totally differently. And so you don't have to worry about if it's like a renal cancer or anything, because you won't learn about cancer till next semester. But just know that the reason they're doing a CT is just to rule out tumors, just to make sure, like, just to kind of see like what's going on. I wouldn't worry, don't go deep into this. Just know that the adrenal cortex releases a lot of hormones, and that includes steroids, and it includes cortisol. Okay, so Cushing's syndrome. So remember, we're thinking like they're really cushy, okay? So this is mostly females. It's actually females for both. The onset is between 30 to 50 years. And I feel like she did ask ages, but it wasn't, there might've been a question that was just kind of like, which patient would you expect to be most at risk for like Cushing's disease? And so they might say like, a male that's, 25 years old, or like those kind of questions. So I would just know, like, you're looking at like middle-aged women for this one. So there's different causes. So it could be a pituitary tumor, like we talked about. So it's, pituitary or adrenal tumor. So either one of those, if it's sitting on top of the pituitary gland or on the adrenal gland, then it can either block flow or increase flow, like depending on where the tumor is and what it's obstructing. And so it can affect one way or the other. And so a tumor can affect it. And I would just know that. You don't need to know like why or how. I would just know like having a tumor can affect, can possibly give you Cushing's syndrome. And then an ACTH secreting tumor. I had highlighted this previously. You don't need to really know small cell cancer. Basically what it is it just goes into, the lungs. It starts somewhere else, and it goes into the lungs. So I wouldn't worry too deep on that, because she's not going to ask you about that. Or long-term steroid use. So this is the one that you kind of need to know, because this is the one I think they really focus on, because these ones are cancers, which you'll focus on more third semester. So you do need to know that different cancers is a cause of Cushing's syndrome, but the one they're really going to focus on is this long-term steroid use. Oh, I had a quiz. Okay, we'll do a quiz at the end. I forgot about that. So iatrogenic, know this term. This was on our test and I missed it because I forgot it. So iatrogenic means that a doctor or a treatment or procedure inadvertently causes some sort of like adverse condition. And so it's not considered like a side effect or just like a contraindication or anything. It's more like for this, for instance, when a person is on long-term steroid use, then they can develop Cushing's syndrome over time, or if they're like on a high dose over time, they can develop that. Now, the doctor wasn't trying to cause that. It wasn't a mistake on the doctor's end, there was no medical error that he has to report. It's just something that happened. And so that's what's iatrogenic. And so it's something when we're giving a treatment for something and then it causes something else. So like another example is like, when people get radiation for cancer, sometimes it can cause like burns. Well, that'd be more like a side effect, but radiation can cause like conditions that people have. And so then that would also be like iatrogenic. So just know that term and like what it means. Okay, so basically what's happening here, and I'm not going to go too deep because she doesn't, like, you won't really have to know super the MOA, but just so you understand what's happening is you have an issue with this negative feedback loop. So the hypothalamus releases CRH and to the anterior pituitary gland. And then that tells the anterior pituitary gland to release ACTH. And ACTH tells the adrenal cortex to release cortisol. So each hormone is telling a different gland to release a different hormone to act on the body. And so it's kind of this big pathway. Well, when enough cortisol is in the body, then it's going to be a negative feedback loop where it tells the anterior pituitary gland and the hypothalamus, like, hey, you can stop now because there's enough cortisol in the body. And so normally in a healthy person, this works where the cortisol is like, okay, red light, stop. And then the hypothalamus and the anterior pituitary gland are going to stop releasing their hormones. And so then that balances out the cortisol in the body. But in Cushing's, this feedback loop is not working. And so the cortisol keeps going up, but these glands, for some reason, aren't stopping. And so they're continually releasing these hormones that make the adrenal cortex release more cortisol. And so this is broken. Okay, so this is what you're going to see. You're going to see hirsutism, which is excessive hair growth. So make sure you know that word because that's what they'll use. I feel like there were a decent amount of select all that apply where it was like a patient has Cushing's syndrome. What signs and symptoms would you expect to see? Select all that apply. So make sure that you know which signs and symptoms go with which condition. And then you're going to see like these fat pads. So there's more right here. So I just think with Cushing's, again, it's anything to do, like a lot of this has to do with weight gain. So having like kind of that moon face, like, or a buffalo hump, like it's just extra weight, right? So extra pads of weight. And then having abdominal striae, that's just, it's stretch marks. And so when people gain a lot of weight, they gain stretch marks. So again, it all has to do with weight gain. Hirsutism, someone told me the way to remember it is hairy-suitism. That's how you remember it's extra hair. So hirsutism is extra hair, poor wound healing. And that's because their skin is being stretched so much that it's so much thinner. And so it's harder for their wounds to heal because everything is stretched out. And then diabetes mellitus and hypertension, we often see with weight gain, right? And so just again, remember weight gain, you're going to have diabetes mellitus and hypertension. And then for osteoporosis, that has to do with that we're taking away, I wrote it down now, I can't remember what it was. I wrote it down, I'll go over when I get there, but we're taking away calcium from the bones. I can't remember why, but I wrote it down. So, but basically it's taking away calcium from the bones, and that's why we have osteoporosis. So you have that weakening of the bones. And then you definitely need to know for each one, whether like what your labs are going to look like. And so potassium and sodium have kind of that inverse relationship, right? So if you have high sodium, a lot of times you have low potassium and vice versa. And so the way I remember these ones is again, weight gain. So if you have high sodium, then a lot of times you have high fluid, and then you have kind of this like edematous, but puffy look, right? And so that's again with Cushing's, you kind of have this puffy look. And then if you have a lot of sugar in your body, I think, oh, if you eat a lot of sugar, you gain weight. And so again, weight gain, you have that puffy look. So that goes with Cushing's. And so if these two are high, or specifically if sodium is high, then potassium is going to be low. So that's kind of how I keep those straight. And then if you can keep one of them straight, it's just the exact opposite in the other. So for me, it's easier to keep it straight here because I think of weight gain and how it affects everything. And then I'm like, and then in Addison's, it's the exact opposite. So this is one of those that, remember I said, like, if you can have a blank piece of paper and kind of write down everything before the test, as soon as that test opens and you're allowed to start writing on your paper, I would write down this, like, okay, Cushing's, hypokalemia, hypernatremia, hyperglycemia, and then right next to it, like opposite for Addison's or whatever. And then that way you don't have to stress about remembering this. Okay, so we already talked about these. This is just saying that it's the amount of cortisol in 24 hours in a urine sample. So they'll test your urine to see what the cortisol levels look like. And so normally you would only have so much cortisol in 24-hour catch of urine. but you will have really high if you have Cushing's. You probably don't need to know this. I had highlighted this previously because I thought maybe I needed to, and it wasn't on the test. So you can't, I tried to study this and I kind of got confused about it. But then it wasn't even on our test. So if you like, it could be, but it wasn't for us. And then of course, like, so your urine cortisol is high, and then also your plasma cortisol in the blood is high. And then you'll have metabolic alkalosis. And there's a reason for it, and I can't really remember, like there's a whole patho involved with that. So I personally, I'd probably just memorize that, like one or the other, because it's going to be the opposite for Addison's. So that's the nice thing about these two diseases, is if you can just like remember one really well, then you're 95% going to know the other one, because you can just think it's the opposite, it's the opposite, it's the opposite. So, so that is the good thing, is like, I would focus knowing one really, really well, and then making sure that the opposites are correct. And then any sort of like discrepancies, then that's all you have to learn for the other one.
It looks bad now. I don't know why it's messed up.
Let me, all right, you're off mute, whoever that was. I don't have my button to mute people. Let's see. This is just saying, like, it's the difference between whether it's primary or secondary. They did not test us on this. So it's one of those things where I never know how deep to go into something. So when I'm studying, sometimes I go way too deep into something. And this was one of these examples where I went too deep on some of the A&P and patho, and it wasn't helpful. It was just confusing. So I would not worry about primary versus secondary. They're not going to ask you that. Well, I shouldn't say they're not. I'm 95% sure they won't.
So Sangil put on her notes here that on the metabolic acidosis or alkalosis, it says increased sodium causes increased, I guess, hydrogen excretion, decreased potassium. It was talking about HCO3 retention.
Oh, okay.
So, and that's what leads it to the alkalotic state.
Okay. Yeah, that makes sense. So yeah, so if that helps you to remember it, sometimes knowing the patho is helpful, and sometimes it just makes it more confusing. So sometimes I go deep in learning the patho because then it helps remember, and sometimes when I go deep, I'm like, now I'm just confused. So you have to pick and choose whether or not it's going to be helpful, or if it's just easier to remember it. So whatever is more helpful to you, but that does make more sense. So thank you, Stacy. Okay, so you're going to get a history, like, do they have a history of tumors? Because if they do, then that's, well, it's not easy, but it can tell us this is what's causing it. Infections, they're going to be more prone to infections because of all the cortisol going on. And it's just going to interfere with their immune system. Change in weight, they're going to gain weight. Change in appearance, just like this little boy right here. So this is the same kid. So a huge change in appearance. So they're going to have like issue with body image, increased bruising and weakness. So, okay, so this is where I talk about it. So first of all, so thinning of cortisol, or increased cortisol, leads to thinning of skin, which leads to easy bruising and stretch marks. So that's the striae. So they'll call it striae on the test. And then increased cortisol leads to thinning of bones, resulting in osteoporosis. So cortisol can impair the intestinal absorption of calcium and renal absorption of reabsorption of calcium. So you just have less absorption of calcium, and so then that thins out your bones. So physical, again, different appearance, hair and fat distribution, muscle size and strength. So that's kind of what we already talked about. Okay, so I had put know the MOA of the drugs, and I worked really hard to remember them, and then it wasn't even on there. So I don't know, because did Martin or Sangil like tell you guys to know the MOA of these drugs?
There's some typing next to it. So the first one, metallotine, kills adrenal cells, and then with the PASIR, I don't know how to pronounce it. I don't know, but she has some writing that she provided on her notes.
Okay. So I would go by whatever your professor said. I know for Martin, I don't remember if she said to know it, but I memorized it and then it wasn't on the test. Martin normally does not ask for mechanism of action of drugs, like unless it was like the GI with like knowing like PPIs and how those work and stuff. But normally it's more like side effects or just like what drugs you should take for certain like diseases or like conditions. She very rarely asks for MOA. So I probably wouldn't worry about it. I would just be familiar with these so that you know the medications that you're going to give for Cushing's, because she will ask, or she asked us like the medications you would give, what you would expect to see. And then they're going to have a diet low in sodium. And again, that's because they already have high sodium and they're pulling in all that water and weight. And so we want to do low sodium. And then we're gonna, if it's because of a tumor, we're gonna do chemo or radiation or cut out the tumor, whatever we have to do for that. And then we're gonna decrease, like if they are on a high dose of steroids or continuous steroids, we're gonna decrease the steroids, but do it slowly. If we do it too fast, then we put them in an Addisonian crisis. And that was a test question for us. So make sure you know that stopping steroids really quickly can put a patient in Addisonian crisis. So we're always tapering off steroids slowly. And this is just talking about removing tumors. If we do remove an endocrine gland, then we need to replace with hormones like lifelong, because now that endocrine gland, whatever we've taken out, if it's adrenal or if it's the, what's the other one? Adrenal or pituitary, then now it's not able to release hormones because there's nothing there. So we have to make sure the patient is on lifelong hormone treatment because they still need hormones in their body to do the job that they're supposed to do. Okay, these are just like nursing problems. I think that if you're doing priority, it's probably going to be the dysrhythmias, right? Because that affects your heart. Maybe risk for infection. Possibly electrolyte imbalance, but I would say like mostly potassium, which is going to go into then dysrhythmias. I don't feel like they really have you put them in order. Sometimes I guess they'll ask for priority. But I would just, I feel like for this one, they didn't really ask for nursing diagnosis or problems on this test. Okay, so now we're going to Addison's, which is pretty much the opposite of what we were just learning. So just think everything opposite of Cushing's. With a few discrepancies. So basically, they are going to have an underproduction of cortisol. And so this could be for a few things. It could just be an autoimmune disease, or it could be like secondary either diseases or damage, like some sort of trauma. I wouldn't worry too much about this. Like exactly this, like this decreased secretion. I would just worry more that like basically so this is kind of what we talked about up here. So we're having decreased secretion of this, which is causing decreased secretion of this, which is then going to cause decreased secretion of this, right? So they all act on each other. So if your hypothalamus is not producing a lot of this, then there's not going to be very many little people to say, hey, pituitary gland, produce some ACTH. So there's only a couple of them. And so the anterior pituitary is like, oh, it's not a big deal. I can just release a couple little guys. So they release a couple little guys. And then the ACTH is like, oh, it must not be a big deal. And so they go to the adrenal cortex. The adrenal cortex is like, oh, must not be an emergency. And they just release a couple little cortisols. And really the problem is up here. And so this is not getting released as much as it should. And so then there's not a lot of cortisol going out, even though your body does need a certain amount to keep up with all of the systemic functions that it has to perform. Okay, so this is kind of explaining adrenal insufficiency. So the pituitary, so again, what I was talking about. So the pituitary gland is not stimulating the adrenal glands. Remember, they sit on top of the kidneys. So then the adrenal glands are not releasing cortisol. And so either it's a very little amount or it's none at all. And so then we have an issue, the opposite of what we have with Cushing's, where it's not being released. So again, it's the same age range, 30 to 50, and females are more likely than males. So they're both middle-aged females. It's mostly autoimmune with a genetic link. It could be a pituitary tumor. And remember, it could also be abrupt withdrawal from steroid therapy. So with Cushing's, it was too long of steroid therapy or too much. And then with Addison's, it's the opposite. So now you're not getting enough steroid therapy because you stopped it so quickly, and that caused an Addisonian crisis. If it's an autoimmune, that's not curable, and they're just going to have lifelong treatment. If it's abrupt withdrawal from steroid therapy, we can fix that by putting them back on steroid therapy and slowly taking them off, and then they should be able to recover from this like Addisonian crisis. Okay, so remember, we're going to have the kind of the opposite. So because we have decreased glucose, we're not going to have a lot of energy. So we're going to feel fatigue. We're going to have muscle weakness because remember, glucose is like our body's energy. Nausea, vomiting, and abdominal pain. That you're just going to have to memorize that because I don't have like a good, like, this is how I remember that. You have decreased sodium because remember, in Cushing's, you have high sodium because it contributes to fat. And so in Addisonian, you have the opposite. You have decreased sodium. So you're going to have these salt cravings because you don't have enough sodium. And then you're going to have anorexia because you don't have enough glucose. You're going to have hypotension related to dehydration, which I don't quite understand this link right here. Did Sango or Martin explain this very well?
Water follows salt. So if our salt is low, then our overall volume is going to be low.
That makes sense. That makes sense. Okay, yeah. So not enough water because we don't have enough salt. And so then we're going to have dehydration. So also hypotension. So our fluid deficit. And then osteoporosis, hyperpigmentation. And then these are all the opposite of what we were looking at with Cushing. So we have hyperkalemia, which can affect your heart rhythms, right? Hyponatremia and hypoglycemia. Okay, so these are just kind of the same things. So remember, if you're dehydrated, then your BUN is going to be increased and your H&H is going to be increased with dehydration. We have decreased cortisol because that's what's causing this whole thing. I would just remember this. ACTH is increased in primary. It's kind of confusing when you go through the whole pathway of like ACTH increased in primary but decreased in secondary. I tried to learn it and it just really confused me. So I don't even think she'll ask you that because this was not asked on ours. But if this is just something you just need to memorize, I would just memorize it. And then again, CT scan, same reason for Cushing's. It's just to rule out tumors, to just see what is causing this. Okay, so our treatment is we're going to add steroids. So Addison's disease, add steroids. Oh, this is a test question for us. Increased stress can cause an Addisonian crisis. So if we have a lot of stress going on, if a patient with Addison's disease has a lot of stress, but then cannot release that cortisol, then they go into an Addisonian crisis. So high stress for a person with Addison's disease can put them in Addisonian crisis. So just know that. And so if a patient so this was also a similar test question. So something like, I think it was something like a patient with Addison's disease is going to be going into like a high stress situation. I can't remember. Like she had some whole like scenario about a high stress situation. Like what treatment would you expect the provider to give or something? And it's going to be increasing the steroid treatment. So because they're not producing cortisol, which is like steroids, then we are having to go in and do that for them. And so we are having to give steroids and we have to give more if they are going under a lot of stress to kind of help compensate because their body is not doing that like it should. Oh, and including surgery. So surgery is stressful for people, right? And so a lot of things for surgery, like people's glycemic levels go up and their white blood cell kind of is all over the place because it freaks people out. And so their stress levels are going to be through the roof. So if they're going to go into surgery, we're going to increase their steroid treatment to just kind of compensate for that stress. So here's some steroids that you're going to see. So just know your steroids. If they have high potassium, because hyperkalemia is common in Addison's. We're going to give K-exolate to decrease it. And remember, potassium affects your heart, so dysrhythmia. So it can be potentially fatal. And so that's why we're going to make sure that we're keeping their potassium levels in check. IV fluids, because they're dehydrated, so they're going to have weight loss, skin changes, which is pigmentation, nausea, vomiting, weakness. We kind of went over all this, decreased weight. And just realize hormones isn't like a cure. It's just a lifelong hormone treatment. So it helps, but it's not like it cures them, right? They have to take it lifelong to manage this disease or this condition. Okay. Addisonian crisis can cause critically low BP, which can lead to death. So remember, they are losing all this salt. They don't have enough fluids. And so it can cause like really, really low BP. So we have to make sure that we are giving fluids when people are going through Addisonian crisis. That's the first thing that we're doing is fluids. And for diabetes patients on hormones, we need to increase their insulin because their blood glucose is going to be higher because of the hormones. Okay, so this is just a little thing I found online, and I had, I whited out some of their information and put our own that like matched what we were being taught. And so if this is, I like sometimes having things side by side so that I can see like the differences. So this is everything we've already talked about, but if this is helpful for you to just have it side by side, I would look at this one. And so first we're doing IV fluids. So I feel like that was on our test. IV fluids first and then push steroids. Okay, so you guys already went over these questions. We can just go through it one more time.
What you just said was that, which one was that, for Cushing's or Addison's, where you said IV fluids first?
So that's going to be for Addison's because
Addison.
for Addison's, they need fluids because they're dehydrated. For Cushing's, they're kind of fluid overload, like, because they have so much sodium.
That's right. Thank you.
Yeah, no problem. Okay, so client comes into the ED with Addisonian crisis. Which of the following should the nurse be prepared to administer to assist this client? So IV fluids, right? Because they're super dehydrated. So warm blankets, they're not, they might be cold, but that's not going to be like our first priority, right? Thyroid replacement hormones, they don't have issues with their thyroids. These are hormones coming from different spots. So it's not their thyroids. And a blood transfusion. There's nothing that says that they're hemorrhaging. So we don't need to give blood. So we're going to give IV fluids because they're so dehydrated. So the treatment for Addisonian crisis is IVNS and steroids via IV push, and then IV dextrose solution because they're hypoglycemic. And so we need to give them sugars. And so we're giving fluids before steroids. A client with intractable asthma develops Cushing's syndrome. This complication can most likely be attributed to the chronic use of prednisone, theophylline, metoprolol, and cromolyn. I don't even know what this is. I kind of don't know. I don't remember. I kind of like, this is a beta blocker, I think, right? Maybe. I don't know. But I know this is a steroid. So I usually go through the medications. I'm like, I don't know this. I'm very bad at pharm. I don't know this. I don't know this, but I know what this is. And so go through the ones that you know for sure. Because a lot of times I feel like they like to like send you into a panic by throwing in medications that you've never seen because it makes you go like, oh my gosh, I don't even know what this is. And so you guys probably know more pharm than I do. I'm just not very good with my pharm. But I would just go to the ones that you know. And so I would go, okay, prednisone, I know that's a steroid, and I know that steroids, like too much or too long, can cause Cushing's. And so that would make sense because people with asthma, sometimes we give them steroids to help like dilate like the lung vessels and everything, right? So they can breathe better. And so that it's going to develop Cushing's from that. I think, okay, that was it for that one. Okay, so now renal. Okay, I don't think that they're going to ask anything about A&P for renal. you should hopefully by now know the renal system. So just make sure you know where everything is. You don't need to know deep about like the glomerulus specifically, but just know the basics. Make sure you do know the function of the kidneys, because they might ask a question about like if you have like impaired kidneys, how, like, what would that affect, right? So if you have impaired kidneys, then you're gonna have trouble excreting urine, right? Like if urine can't get filtered through the kidneys, or the blood get filtered to produce urine. And so then you're gonna have like minimum urine output. You're gonna have a high, or you're gonna have like issues with like you're gonna have low GFR. You're gonna have problems with like your BUN and creatinine. So you're gonna have a lot of issues. Also, they produce erythrocytes. Well, they produce erythropoietin, which increases erythrocyte production. And so if they're not secreting erythropoietin, then your bone marrow is not producing red blood cells. And so then you're going to have a problem with oxygenation, because now you have no red blood cells to carry oxygen to all your tissues. So your kidneys are super important, and they do all of these things. Okay, so I would know your normal lab values just because are they, so for us now, because the NCLEX puts values, like gives you the values, for third semester, they're giving us the values a lot of the time. Are they giving you guys the values?
No, but I wish they would.
Okay. I know that they had talked about like throughout the program, like changing that over, because now NCLEX, like the new test gives you the values. Oh, so San Gil doesn't, right? That was that Erica that said that?
Yeah, St. Gil doesn't.
Okay.
That I've noticed. I could be wrong.
Does Martin?
No.
No. Okay. Okay. So I know that they talked about like them, like the nursing program, because I was talking to Debbie about it, and she said that like because the NCLEX now gives it to you, like it doesn't make sense that they would make us memorize it, because what's the point, right? But I just think it hasn't filtered down yet. So in third, they are really good about, they give you the values and then you can compare. But I would know these values because for renal, they're going to ask you questions and you're going to kind of have to know. Again, I wouldn't memorize male versus female, just memorize the low and the high, because they're going to make it way out. And I have never memorized the difference, and it's never been a problem for me. So I'd probably just know one or the other. And then GFR is the amount of filtrate produced in 1 minute. So if you have, so you should have a certain amount. You should have so much urine being produced in a minute. If you have too low, then something's going on with your kidneys where you're not producing enough like filtrate or urine like in a minute, right? And too high is usually like fluid overload. Too low usually is either the kidneys aren't working or you have like dehydration issues. This is probably just, well, for San Gil, since she doesn't do quiz questions, you might need to know these. I feel like Martin maybe puts like 1 on her test, but I feel like these are normally for quizzes.
For St. Gil, she didn't give us a slide for those, thank God. So hopefully she'll.
Oh, okay, then don't worry about it. No, she only tests on your slides. I'm gonna skip all of these just because I don't think I had highlighted this for my personal information like last semester, and she didn't even test on that, so I wouldn't worry about that. Okay, all right. Okay, so the majority of renal calculi is like a kidney stone, right? And the majority of them are calcium stones. I don't think you need to know that. I don't think they test you on that. And you won't need to know like the different, just know there's different types. You don't have to know like, oh, like there's also uric acid or struvite or xanthine. Like they're not going to ask you that. I don't even remember if they asked if the majority are calcium stones, but I know Martin talked about it, so she might ask that. So you have 3 contributing factors of why you develop renal calculi. So first is supersaturation. And what that is that you have too many salts, not enough fluids in the urine. And so when your kidneys are producing urine, it takes all the blood and it filters everything out, right? So it filters out certain like electrolytes, it filters out urea, just like certain like waste products. And then it pushes things back into the body that it's like, okay, actually you need this. So it reabsorbs things, or it just excretes waste. So if you have too many salts and not enough fluids in the urine, the way I think about it is I kind of think about it like clots. Like, you know, when you have like you kind of have like blood stasis and nothing's really moving around, and so then it just kind of slowly coagulates. I kind of think about like it's kind of like that with the salt. So if you have all these salts that are like just a bunch of them and they're starting to like kind of coagulate together because you don't have enough water kind of pushing them through, then they're going to crystallize and form like a little rock. And so that's why we're like, drink lots of water. The more water you drink, the less likely you are to get kidney stones. Nucleation is just free ions such as calcium and oxalate spontaneously joined together to form a solid crystal. I don't think you need to know this word. This was not on our test. I'm just explaining it in case like, I don't even remember if they asked about contributing factors. I feel like they didn't, but just in case, just so you kind of know what they are. Inhibitory substances, these are just things that naturally are in the urine that they prevent these free ions from turning into kidney stones. So just basically your body's natural protection from kidney stones. But like sometimes maybe you lack these, whether it's genetics or just over time, and then you're more likely to get kidney stones. So aggregation is just when you have crystals that are already formed, then they can sometimes begin to join together, and like they're not actually growing like we think of growing, but it's more like aggregation. So they're kind of building on one another and clumping together. Okay, so lithiasis is just stone formation. So nephrolithiasis is in the kidneys, urolithiasis is any part of the urinary tract, ureterolithiasis is in the ureters. So that should be pretty like, just look at the first word and see like what it is. I don't think they'll ask you the difference between them. I would know your risk factors. So industrialized countries, I think, I am just guessing. I think the reason for that is because we have crappy diets and we don't drink enough water. I really think that's why it's more common, and we're fat. So I really think that's why we're more likely to get it. So in the US, specifically the South or Midwest, why? Because people eat like crap there, and they're chunky. So, and I moved here from Kansas, so I feel like I have every right to say that. The food is delicious, but people are chunky. Males more than females, Caucasians and African Americans, family history, dehydration. Remember, we need to drink lots of water to get those salts flowing through the kidneys. Immobility, and then all of these things right here can produce crystals. So calcium, oxalate, protein intake. Make sure you know what oxalate is, because there will be a question, like a diet, well, on Martin's. I don't know about Sangil. I think today she was even like, I don't really like these questions, so you probably won't have to worry about it. But on Martin, she really likes those food questions. And so there will be like probably like an oxalate question. So make sure you know like no oxalate for patients that are either at risk or continually get them. We're going to be like, hey, like don't eat these certain foods. If they have gout, urinary stasis, or hyperparathyroidism. I don't feel like they asked us about the, maybe it was more of these ones for the risk factors. So oxalate, you can see it in like leafy green vegetables, nuts, spinach, which is leafy green vegetables, wheat bran, chocolate, and tea. Okay, so this is just explaining kind of what's happening with kidney stones. So they form in the kidneys. When they're in the kidneys, you usually don't have any symptoms because it's a pretty big spot for them to kind of sit and hang around. We really usually don't have any symptoms until it starts moving down, because then it can get stuck in the ureter in this tube, or it can get stuck in the, well, the ureter, sorry. It gets stuck in the ureter, or the urethra, right? And so that's when we start having, like really start feeling it. Where, I mean, sometimes you can feel it up here if it gets stuck like up here in a callus, or calyx, but normally we're asymptomatic there. And this is just kind of showing how it's forming. So this is what it should look like, nice and clear. And then see, these are crystals that are just starting like just kind of just congregate, and now they've smushed together and formed a stone. And that's called aggregation. And again, this is just showing there's all these different kinds. You do not have to remember these at all, but it's just showing that like there's different types and they're formed from different compounds in the body. Okay, so I do feel like they asked the difference between these, like whether it's kidney stone, bladder stone, or your I don't know if I'm pronouncing that right, stones. So know what renal colic is. I feel like that was a question on ours, like renal, like what it was. So it's acute severe flank pain. So it's really, really severe pain in your flank, right? So that's right here. And so it's going to radiate to the suprapubic region, which is like right here. And external, it could radiate to the groin, external genitals. You're going to have nausea, vomiting, pallor, cool, clammy. With all of them, you can get a UTI. And that's because the stone is blocking either in here or it's blocking something here. And so then you have urinary stasis. And if the urine is just hanging out, then it's more likely to either cause hydronephrosis, which means it's backing up into the kidneys, or it's a perfect reservoir for bacteria, right? And so if it just like sits and is doing nothing, then you're going to have bacteria start growing. And so you're at risk for UTI with all of them. And so especially elderly people, a lot of times when they come in to the hospital and they're in there for UTI, because for elderly people, like UTIs kind of get out of hand, right? And they just can't recover for them. And so they end up in the hospital with sepsis. And a lot of times it's because they had a renal calculi, at least from what I've seen. Stacy, have you seen kind of the same thing?
It can happen, yeah, a little bit.
Okay. Maybe it's just Bakersfield or my luck with patients, but I feel like the majority of my elderly patients that come in with UTIs is because they have kidney stones that like either they didn't know about or they kind of knew about but weren't really taken care of. And so then they got a UTI.
I think that just goes back to all the age-related changes that they don't notice some of the things that maybe a younger person would.
Yeah, like either they're just so used to the pain or they just don't feel it. Like I don't really know which it is, but sometimes I'm like, wasn't this bothering you? And they're like, I'm like, oh my gosh, like dang, gangster. Okay, so the pain is due to the edges of the stone becoming wedged in the ureter until the stone passes. And so it just like it's scratching against the inside of your ureter. So it's like really painful. So I would just know the difference between the two. So this one, you have dull aching flank pain for kidney. For bladder stones, dull suprapubic pain. And then kidney is the microscopic hematuria, so blood in the urine, but you're only going to see it under a microscope. And then for bladder stones, you can see gross hematuria, which means you see it with your eyeballs, or microscopic. So either one. So I would just know differences between those ones. Okay, a major complication, we talked about UTI already, and hopefully you know what the signs and symptoms of UTI. Hydronephrosis, this is what they might ask you about UTI, but that's more first semester. So they will probably ask you about, well, they will ask about hydronephrosis. So what's happening here is you have a renal calculi that's either stuck here or here somewhere, and it's stuck somewhere where it's causing bladder to back up into one of the ureters. And so when it does that, then it's just going to expand. It's going to go back into the kidneys, expand. So not only can you have a UTI, but now you're putting all this pressure on the ureter and it's going to cause like kidney failure basically in this kidney. And so we need to take care of it fairly quickly because we don't want to lose a kidney, right? So we need to really, it's fairly emergent. So when that happens, you're going to have acute colicky pain, which that means it's like pain that like comes and goes. Like all of a sudden it's going to be like so painful, and then it kind of goes away, and then so painful. So that's what kind of colicky is. It can radiate into the groin and abdomen. Hematuria, pyuria means pus in the urine. So know that term. Fever, nausea, vomiting. So it's kind of similar to UTI, but there's a few differences, like this acute colicky pain. Okay. And so that's if it's acute. If it's chronic, like it continually happens, then instead of acute pain, it's going to be more of a dull aching flank pain. You're still going to see hematuria and pyuria, still a fever, but then a palpable flake mass. So I highlighted the differences between the two. So you can kind of see, because some of them are the same, right? But then you can see what stands out. Okay, when we are looking to do a test on a patient, our number one diagnostic test of choice is non-contrast CT. Why would it be non-contrast?
Allergies. And
Maybe.
less invasive.
Possibly from like the kidney stones causing like kidney problems, so you don't want to
They can't.
overlook them.
You already have the kidney failure.
Couldn't you visualize them better without the contrast?
Kidneys are the main thing that excretes all the stuff.
Okay.
So if the
Yeah.
kidneys aren't functioning,
Yes.
You're gonna have all of that radioactive stuff.
Yeah, exactly. That's perfect. So, Erica, I'm not sure if you would see it better with contrast or not. I don't really know. Like, I know a lot of times we see things better with contrast, but maybe with kidney stones, we don't. But the reason why, like, if they ask you, like, why would you, like, would you question this, or like, what would you want to do? You want to do non-contrast if possible, because it can be iodine, and like the contrast is nephrotoxic, like, so it's harmful to our kidneys, right? And so because we already have this kidney issue, we don't want to give them more stress. And so they have to really work hard to excrete the iodine. And in a healthy person with great kidneys, it's fine. Like, our kidneys can work under stress. But if you already are stressing out your kidneys, like, let's not make a problem even worse, right? So we're going to be very careful with what we're giving the patient. So that means we're also probably not going to give them ibuprofen, right? So we're going to be looking more at like acetaminophen or morphine if they have really high pain, hydrocodone. So we're going to stay away from ibuprofen, because ibuprofen is also nephrotoxic. So even though they're not in kidney failure, we're already stressing out the kidneys. And so we're just going to really try to protect our kidneys as much as possible in this situation. So we're going to do non-contrast CT and take out nephrotoxic drugs if possible. So this is just, you don't have to memorize what any of these are going to look like. This is just more like to help you visualize. So this is just showing what a stone is going to look like in like an X-ray. This is a renal CT. This is IVP. So this is, oh, I thought one of them showed you. Oh, it doesn't. So this shows you that it's not blocked. You can see the stone, but it's not blocked. Everything's flowing. And then here do you see, well, they just took the arrows out. So I don't know why they're drawing arrows. I can't see one way or the, oh, maybe it's this little line right here. Yeah, okay. So you have this little line. So here's like the kidneys and the ureters. And so you can see them really well. And then here you can see the one, but you can't see the other. So this little stone right here has blocked it. And so, and I think this is with contrast. I could be wrong, but I think it is with contrast. So sometimes they have to. And if they have to, it's a risk versus benefit thing, right? But if possible, they're going to do it without contrast. So I wouldn't worry too much about like knowing what all these do, or like, I don't think they're going to go too deep into it. I would just know what they're looking for. So for radiology, you can do a KUB, which is just kidney, ureter, bladder X-ray. So they're just going to X-ray everything and see what's going on. They can do a renal ultrasound. They can do a CT scan. They can do an IV pileogram. So these are like these tests right here. They're all looking for the same thing. I think it's just basically different visualizations of it, depending on what the provider is looking for. And so I would just know, like, these are the 4 tests they're going to do. And then for your lab test, they're going to do your analysis to see if you have a UTI, and then same with a culture. They're going to culture it to see, do you have a UTI? So they're going to check for that first, or not first, but they're going to check for that because it's possible that you can get a UTI with a kidney stone. They're going to check your levels to see like what's causing the kidney stone, because then they know how to treat it. And then, like, again, they're going to check your levels and see like what's causing it, because they're like, oh, it's high oxalate. They're going to be like, okay, let's lower like the oxalate in your diet. So they're just looking for what's causing it. And then they'll chemically analyze the stone. So once you excrete them, then they're going to analyze it so they can figure out what's causing them, so that you don't have a recurrence of stones. Because once you've had them, you're more likely to have them again. And so if it's because the patient like eats a high diet of oxalate, if it's because like it's due to dehydration, then we're going to help the patient manage their diet to help them to not get this again. Okay, so analgesic. So this is most important to the patient, obviously, because they're in so much pain. So we're going to give morphine, hydromorphone. It's very painful, so we're going to give them good analgesics. Increase hydration because we want to get that urine flowing to get those salts out of there. Most, or 50% of, which is a good amount, of stones are less than 5 millimeters and pass spontaneously. So it's painful. We're going to give them drugs, but we don't have to like go in and do any sort of invasive procedures. We're just going to let them pass on their own. So it's called a trial of passage. And then possibly antibiotics if they have a UTI, then we'll give antibiotics for that. In general, we don't need antibiotics for renal calculi, only if there's a UTI. Okay, and then low sodium diet, high citrate intake, and low oxalate intake. I don't think that she'll, I think, you know, like low sodium, so no French fries, right? You need to know oxalate. I don't think she'll ask you foods and citrate. I don't remember that. I would know high citrate intake. But I forgot to put foods on here and that. So you might want to look it up just in case, but I don't think she'll ask you that. Like specific foods. Okay, so with all these different like treatment, not tests, what's it, procedures, I would not worry about like, they're not going to ask you like a patient's undergoing ESWL, like explain the procedure, right? So I would just know like the very basics. So I would know like they might ask a question like a patient has renal calculi that they're not able to pass on their own. What diagnostic or what procedures could they possibly have? And so just be able to recognize them. You could be like, oh, like they could have this procedure, they could have this procedure. So just like the names of them. With all of them, we are straining the urine. There is a question, or for us, there's a question like this, like, what are you doing as the nurse? You're straining the urine because you want to collect the stone fragment so that it can be analyzed by the lab so they can figure out what's in there. And also to make sure that it's working, because if they're getting this treatment done and they're not passing any stones, then it didn't work. And so we need to make sure that we can tell the provider like, yep, they passed a bunch of stones, like here they are, or whatever, right? If they have bruising on their flank, then we can put cold packs on there just to help them feel better. So this is just basically, it's a shockwave that goes in and breaks up the stone. And then because it's smaller, it should be able to come out in the urine without an issue. This is just ultrasonic, like exactly what it says. You do not have to go deep into this or even know exactly what it does. It says right here, ultrasonic. So it's using sound waves. So if you see lithotripsy, it is the exact same as lithroscopy. In the book, it says lithotripsy, but then Martin wrote lithroscopy, and I was like, what the heck? So I went and asked her, and she's like, oh, it's the same thing. So either one, if you see one or the other, it's the exact same. And then retrograde uteroscopy, and then I would just know that surgery is rare. So the majority, like very, very few patients are going to actually go into like surgery. Like most of these are outpatient procedures. It's not very invasive, but it's not like invasive surgery. It's only if they're like ginormous that there's no way they can like break them up without going in and removing them. So this just explains, well, I guess this one is under general anesthesia. So that's a little bit more invasive. A flexible scope is inserted through the urethra bladder and ureter to ID and remove the stone, but it's still not like considered like a surgery. It's more like a procedure. Okay, so again, the big thing, we're straining the urine. I think it says that like 4 or 5 times in these slides, and that was one of the NCLEX questions they had at the end. And I swear that was a test question for us. That is like your number one thing. As long as your patient is not like airway, breathing, circulation issue, you're straining the urine after a procedure like this, okay? And adequate fluid intake, because one of the major reasons that people have kidney stones is because they're eating like crap, they're not exercising, and they're not drinking enough water, because nobody drinks enough water. So we're really going to tell them like up your fluid intake, specifically water. Don't be drinking sodas or caffeine or whatever, like teas, like drink your water. Okay, so lithotripsy is just breaking up stones. So this is the one I think they talk about the most. So I would know this one the most. Again, it's the same thing, lithroscopy, lithotripsy. I would focus on that one. So pre-op, basically the same as a lot of our other things. Ensure assigned consent, make sure they know what's going on. We're going to do bowel prep, so laxative to clear the bowels, and then they're going to be NPO. And I don't know how long, so I don't think they'll ask you that because that wasn't on here. And then post-op, pretty similar, pretty similar to other ones. Monitor vital signs, monitor urine output, straining the urine, looking for stones, and then discharge teaching. So the biggest one here is I would remember bowel prep. They are NPO for lithotripsy, and then we're straining the urine. Okay, so BPH, one of the biggest things with this, not biggest, but one of the questions for us was that it is non-malignant, so it does not put you at higher risk for prostate cancer. I feel like that was a question on ours. So just make sure you know it's not malignant. It's just for whatever reason, it has enlarged like a tumor. And so it's acting similar to how a tumor would react, where it's obstructing other organs and causing like those kind of problems, but it's benign. It's not cancer. It's not going to metastasize anywhere. And we treat it very differently. I wouldn't worry about this. Here it talked about hyperplasia versus hypertrophy. I was like, maybe I need to know that. So I put the definitions here, and it was not for us on the test. But if you want to know, I never know, because maybe they'll stick it on the test, but it doesn't seem like they would. But hyperplasia is just the growth of it's just the number of prostatic cells grow. Where in this one, it's like the actual size of the cell. So hyperplasia is the number of them is growing. So you're going from like maybe 2 cells to 5 to 10 to 20, whatever. And this one, you're still seeing it 2 cells, but the cells itself are actually growing. So that's the difference between the two. So it's only men, because only men have prostates. It's mostly older men, so over 60 years. It can be a little bit younger, but mostly older. So diet is the big one. I know for Sangil, she said cross these out. For Martin, you need to know this. So high fat, high carb, low fiber, that type of diet is it's a risk factor for BPH. So I put examples here, and I'll resend these out so you have these. But hopefully we all know what high fat foods are. So all the good food, it's a risk factor for men. Women, we can eat this and get other diseases. High in carbs. So again, all of the good foods we like to eat. And then these are high fiber foods. So you're not getting enough of these. Okay. So they're not getting enough like oats or beans, apples, broccoli, those kind of things. Okay. Okay, so they will probably have a signs and symptoms select all that apply for BPH. So diminished force of urinary stream. So like you go to the bathroom and it's just not coming out like a lot the way that it normally does. Like, when you really have to pee and you sit down, it's just like, whew, it's not doing that. It's like barely anything. Hesitancy in initiating urinary stream. So you're sitting there trying to go and it's just like, it's not coming. It's not coming. Post void dribble. So that's like you go, you think everything's out, and then it kind of like goes a little more. You get like this dribbling. Sensation of incomplete emptying. So you just constantly feel like you have a full bladder, which would be super annoying. Urinary retention. So that is when you go to the bathroom, like you pee, and then afterwards you like, normally we pee and like the majority of the urine comes out. There might be like a small bit left, like 10 mils or 20 mils. That's fine. But it's like they pee and there's still like 100 mils in there. Like they're still holding on to some urine. It's not all coming out. Nocturia is urinated at night. They have increased frequency because again, they're holding on to some of the urine. And so it feels like their bladder is always full. So they're constantly going to the bathroom trying to empty their bladder. So they have this urgency and urgent continence, and then dysuria, which is painful urination. So it hurts to pee. So complications. So because of that urine that's not emptying, they can get bladder distension. They can get infection like a UTI. And that's because remember that urine is sitting there. So it creates that reservoir for bacteria. And then that can create kidney stones. Hydronephrosis, so just like we talked about, like if your urine is just sitting there and there's no place for it to go and it keeps building up, then it's going to back up into the kidneys, and that's hydronephrosis. And then that's going to cause renal insufficiency. So your kidneys aren't working because they're all backed up with urine. It does not increase the risk of prostate cancer, so is not affiliated. So they can do a physical examination. So a digital rectal exam is where they stick their finger up your bum and they feel if they can feel the prostate. So normally they really shouldn't be able to feel this, but if it is enlarged, then they're going to be able to feel it. And they're like, oh yeah, you have an enlarged prostate. They can do a post-void bladder scan. So I don't know if you guys have, I've had a couple BPH patients where I've gotten to do this. It's kind of cool. So they pee and then afterwards you do a bladder scan. And it tells you how much urine is sitting in the bladder. And so it shouldn't be like, I don't know it's probably different per facility, like what the number is. But if it's like a certain amount, it's like, okay, this is too high. And they're like, no, I got everything out that I could. Then it's like, okay, we have a problem now. So they can diagnose it that way, or they can do post-void catheterization. This is not preferred because you have a risk of infection every time you cath a patient. But for some reason, if they have to, or I don't know why they would choose this, but what they'll do is they'll have the patient urinate, and then afterwards they'll put a straight cath in them and see how much urine they get out. So it's the same idea as this. They're just seeing how much urine is left, but this is less invasive. Tests, they're going to do BMP. They're going to do UA to see like, do you have a urinary tract infection? Is that because it's a lot of similar symptoms as a UTI, right? Where you have increased frequency, painful urination, nocturia, like a lot of it is like a sensation of incomplete emptying. This is really similar to UTI. So you're going to do a UA to like see, like make sure there's nothing else going on. PSA, I'm going to talk about that in a second. And then KUB and IVP. So this is, they're just, they're doing an X-ray and an intravenous pilogram. So that's just to make sure like there's no like tumors going on. Like they're just like taking a good visual of the whole urinary system to see what's going on. So the PSA, it's a lab that they do. I don't know if you've seen it before in any of your patients, but it stands for prostate specific antigen. You don't need to know that. But an increased PSA can indicate BPH. It can also indicate cancer. And so it's not definitive. So they'll do a PSA, and if it's high, then they can be like, okay, it's either BPH or it's prostate cancer. And so then they'll do further testing to see, like, that's probably where this comes in, because then they can see like, okay, it's just enlarged. There's no tumor on there. And so it can be one or the other. So it's not like specific to cancer or BPH, but it's specific to the prostate. Okay, so for your management, so they have anti-androgen written here, and the book says it too, but the book does not list any specific meds, and Martin did not test us on anti-androgen, so I wouldn't worry about this. Is this on Sangil's slide, the anti-androgens?
Yes.
Did she list specific meds for that or no?
The 5-alpha reductase inhibitors, finasteride.
Oh, is that an okay, I have that right here.
Yeah, Martin mentioned that one too for anti-androgen.
Okay. I have that here. I didn't know that was an anti-androgen. I told you guys I'm terrible with farm. Okay, so, whoa, whoopsies. So these are the two you need to know. So tamsulosin and finasteride. Those are the two that you're giving for BPH. And you don't have to know which one is which. And then for herbal, you're going to see saw palmetto. And then there was another one that Sangil mentioned. Do you guys remember what that was?
African plum.
Oh, okay. I don't think Martin mentioned that at all. But you'll see this one, and they might I feel like Martin did test on this, like what are some medications, and saw palmetto was one of them. So just know that that's a possibility for BPH. And then you're going to avoid antihistamines and anticholinergics because they can make the symptoms worse. So we're not going to give any antihistamines or anticholinergics. So not everyone qualifies for surgery. Okay, so they have to meet certain criteria. So if we can manage their BPH with meds, we're going to manage them with meds. We're not going to do anything different because surgery is invasive and can cause a lot of complications. But if they have some of this, so I would know that that a patient isn't necessarily going to get surgery with BPH. But if they have a question, like they might have a question that's like, well, what would qualify a patient? Or they might give you a scenario like this patient has like all these things, and then you're going to know like, yeah, surgery is a good option. So I would just know the criteria that you're going to look for. So it's basically anything that is complicating the BPH. So if they have chronic UTIs, if they have acute urinary retention, where no matter what we do, that urine's just not coming out, like the medication isn't working. So if the medication works, great. But if they have this urinary retention and medication's not coming out, and we keep having to straight cath the patient, then we're going to do surgery. Blood in the urine, hydronephrosis, or bladder neck obstruction syndrome. Basically, that's just like that the prostate has grown so large that it's obstructing the bladder neck. And so it's squishing it so much that the urine can't get through. Okay, so I just think that I can't remember if they tested us specifically on these. I feel like it was just like we had to know. I would know TERP because that's like the big one. And I would know like the sorry, the names of each of these. Hold on, let me get some water. Okay. So with the trans microwave and with the tuna, they're doing really similar things. So it's both of them is heat. So what they're doing with the trans is they're putting an electrode into the urethra and into the prostate. And then the electrode heats up and it just basically like destroys the tissue through heat, and that shrinks it. And it's really, that's the same thing with the tuna, is they're using radiation to shrink, like burn and destroy the tissue, and that shrinks the prostate. So both tuna and trans is just going to be heat. And then for the tip or TUIP, it's the same thing. What they're not actually taking out the prostate, they're just going in and they're cutting it up a little bit, like putting little incisions, and that relieves the constriction of the urethra. So I think of it kind of like, I don't even know if this is accurate, but it helps me remember, is I think of it kind of like a balloon, and I'm not taking the balloon out, but I'm putting little like cuts in it, and that's going to make it deflate. And so it relieves some pressure. I don't know if that's like accurate and what it's actually doing, but that's what it sounds like to me. Because the tissue is not being removed. We're keeping it in there, but we're just putting little holes in it. So I don't think you have to know anything deep into this, because they're not going to ask you anything deep. I think you just have to know what they are, like the names of them. And then just like the very basic, what I said, tuna is heat, trans microwave, that's easy, microwave, heat. And then tip or TUIP is you're putting a little incision. And then TERP is, I think it's this one. So TERP is the most common one. So this is the one they're really going to like test you on. So they put a resectoscope in through the urethra, and it trims away the excess prostatic tissue, which enlarges the passageway of the urethra through the prostate gland. So I think that's what this is right here. So there's multiple different ways. You don't have to worry about it like which way they can go in. But either way, they're like pulling part of it out, so that way it enlarges the pathway. And just know that BPH, yeah, so this says BHP. BPH surgery can cause impotence, okay? So that is something that men are worried about, of getting in surgery and then they're not able to have a sexual life afterwards. Okay, so post-op, it's pretty similar to like what everything else is. So STDs, pain management, catheter patency. So the big thing they're going to ask you about is this CBI, continuous bladder irrigation. So what it is it's, so like we've seen regular caths before, right? So it's similar to regular cath, but it's, they call it a large bore one. So it's bigger than the normal one that we see. And it has these two, instead of having just like one line, it has two. And so one line that comes out of it is going to have normal saline. And then the other line is to drain the urine and all of the like excess fluid in here. So the normal saline is hung up high. So by gravity, it goes in, it comes up here, and it squirts into here. And it's going at a rate that is almost like a hose. And so what you're doing is you just think of like your bladder, just think of it like if you're hosing down your house, because your house is dirty. And so I'm taking the hose and hosing it down, getting all the dirt off. you're putting this hose into the bladder and you're just like irrigating it, trying to get all the blood and dirt, not really dirt, but blood off the walls and out of the bladder. Okay. So you're just cleaning it out. And so you want to keep it at a high enough rate that everything draining is like light pink. So the first day, you're probably going to see dark red, which is normal because there's a lot of bleeding going on. But then after the first day, it really should be like light pink, and you shouldn't be seeing any clots or dark red. If you're seeing dark red, you need to up the irrigation so that it's just pink coming out, because that means that you're not irrigating enough. So there'll probably be a question that asks like, you notice like clots in the line or dark red blood, what do you do? The first thing you're going to do is up the irrigation solution and see if that fixes your problem, because you shouldn't have any blood clots in the line. That means that this isn't high enough to flush out any clots here. It's blocking it up. So we're irrigating this as much as possible. And then anything in the bladder is draining, including urine. So the patient should not feel the urge to urinate because everything's being drained for them. So just like a patient with a calf, a Foley calf shouldn't feel the urge to urinate because we're automatically draining it. This is the same thing. It's automatically being drained. So it's draining everything out of the bladder, and like all the blood, all the clots, all the urine. So know this purpose right here, because I feel like that was the specific phrase was like a question. So it's putting traction on the prostate. So it's I'm trying to think of another words. You know what traction is. You guys are dumb. So it's basically putting pressure on it to like really like I think of it like you can have a hose on low, or you can have like a pressure washer, right? And the pressure washer is what you want when you're cleaning your house off, because that really gets the dirt off. If I just stick a regular garden hose at my house, it's not doing much. So just think of it as like you want that pressure washer in there, really like getting the walls clean. So that's putting traction on it. It's washing out clots. So to keep the Foley catheter patent, we want to make sure that their urine can drain, because if it backs up, then that's going to cause a UTI and other issues, right? So we really want to make sure that it's high enough to that saline, the solution like flow is high enough to wash out the clots from inside the bladder and also from the line, the tubing. We're gonna assess the catheter every 1 to 2 hours. I'd probably assess it on hourly rounding. Like, is it draining? Does it look patent? What color is like, how much urine and drainage are you getting? What color is it? Are there clots? Those kind of things. How's the patient feeling? Do they feel like they have to urinate? Because if they feel like they have to urinate, then the catheter is probably obstructed, or it's no longer patent. So we need to make sure, like, ask them how they're feeling. And then we're going to assess their labs because they are bleeding, so they are losing blood. So their H&H is probably going to go a little low. So we're just going to check, keep an eye on it to make sure that they're not like hemorrhaging. It's not going super low. So this just explains kind of what I talked about. Okay, so it's talking about oxalate. Here are the oxalate you need to know: spinach, nuts, chocolate, black tea, asparagus. And then again, strain the urine at each voiding. So we're going to ID the calculi. We want to make sure that the procedure is working. That's how we're checking that it's working. Okay, so I'm going to go to the quiz that I made real quick. Oh, where'd it go? Close it. Okay, hold on. I saved it. So this is actually just renal and endocrine. I didn't, actually it might just be renal. I think it's just renal. I meant to put in renal and endocrine and neuro, and then I didn't. So it's just renal, and then I'll create well, on Saturday we'll do Kahoot with everything. The nurse observes red urine and several large clots in the tubing of the normal saline continuous irrigation catheter for the patient that's 1 day post-op TURP. Which intervention should the nurse implement? Are we going to remove the indwelling catheter, titrate the NS irrigation to run faster, administer heparin via IV slowly, or notify the HCP immediately?
B.
Yeah, good. So remember we talked about if we're seeing clots in the tubing and it's red urine, we want it to be light pink, then we're going to up the irrigation and we're going to assess it. So we're going to up it, we're going to assess and be like, okay, now what's happening. And if it's still lots of clots, like if we're upping it and it's still lots of clots and red, then we're probably going to call the provider and be like, hey, FYI, we're upping it a lot and there's still like clots, and just see what they say. And they probably want to come check the patient and make sure they're not hemorrhaging. But normally upping it is going to turn everything pink. It's going to remove the clots out of the tubing. So that's going to be your first thing. I know that Martin likes to do questions about not leadership. What's it called? Is it like leadership? It's like who you can give. Yeah, thank you. Yes. Okay, so Stacy, I don't know if you can do this or not in real life, but in pretend life, the LVNs cannot like assess a patient and be like, oh, hey, the blood is like really red in the bag, so I'm going to up the NS irrigation to run faster, because that would be assessing and evaluating, which is not under their scope of practice. So Stacy, do you do that or no?
That would be assessment. That would require higher level of knowledge.
Okay, so sometimes you're like, no, we actually do that, and sometimes I'm like, I'm not sure. So yeah, so she might have a question that's like, which one would you give the UAP or the CNA, or like, oh, sorry, LVN. No, sorry, not UAP. No, it would be UAP. It could be either. But only an RN can assess what's in the bag and then be like, and then make the evaluation like, okay, I'm going to titrate the NS irrigation to run faster. And now I'm going to see if that works. Okay. So that's not something that LVN or a CNA is doing. Which nursing diagnosis is a priority for the patient after a TURP? Potential for sexual dysfunction, potential for altered body image, potential for chronic infection, potential for hemorrhage.
Priority for the patient's going to be A.
Well, yeah.
But from a nursing standpoint, it's going to be D.
Yeah. So I got this out of a test bank, and there was like a similar one on my test, and I don't remember how she reworded it, but I thought the same thing. I'm like, well, for the patient, it's going to be A, like that's what they're worried about, but we're worried about D. And so if you get this question or very similar, the right answer is D. That's what the test bank said. So I would just verify with Martin, or Sangil. I think Sangil writes her own. I don't think she takes from test banks. But what we're looking for a person with TURP is we are worried about hemorrhage, because they are bleeding actively, and that's fine. That's what we expect, but it should slow down and stop after a while. And so that's why we're really watching the blood output, the urine output. A patient presents to the ED complaining of renal colic that radiates through the groin and nausea, vomiting times 2 days. What diagnosis does the nurse expect? Kidney stones, bladder stones, your ureteral stones, or UTI?
C.
Yeah, C. So C is going to be that renal colic. So that your ureteral stones is the renal colic. A patient is diagnosed with renal calculi. Which statement by the patient requires further teaching? I need to eat a diet of leafy green vegetables. I need to increase the amount of water I drink. I should take the full course of antibiotics even if I'm feeling better. It is unlikely that I will need surgery to remove the stones.
A?
Yeah, A is oxalates. So we want to do, it's a little tricky, because I feel like a lot of times we're like, obviously that's the right answer, because we're always telling people eat leafy green vegetables. But in this situation, there's very few times. One of them is if they are taking warfarin. We don't want them to do leafy green vegetables because that has vitamin K, and then it's going to counteract the warfarin, right? And then also they have oxalates, and so we don't want them to do that if they have renal calculi. Now that's just temporarily, unless oxalates is what's causing it. But this is one of those few times when leafy green vegetables are a no-no. A patient developed Cushing syndrome from long-term steroid use. The nurse understands that this type of acquired illness is called metabolic, spontaneous, iatrogenic, or synergistic.
C.
Yeah, iatrogenic. So that was a question on ours, and I missed it. So you always remember the ones you missed. You're like, dang it. So it might not be on yours, but I would know this word just in case. And I don't remember the question, what exactly it was, but it was something like this. And this was the answer. I was like, dang it. So I guess I did throw an endocrine in there. I forgot that I did that. Okay, so I will send you out my my new notes that I these two, and then also the this practice quiz and my final study guide for MedSurg, and then you can compare it with yours and take what you need to. And then I'll send you out a calendar of for the end of the semester what I have planned, and you guys are welcome if you're like, hey, can you add more? I probably can. If you're like, I'd like a 2 options for final study or whatever, we can do that too. So. Okay, have a good night, guys.
Thank you.
You're welcome.